welcome everyone to our Research Connect series. My name is Christelle Hogg. I am a registered dietitian and I work at the CHUM Research Center in Montreal as a clinical research coordinator. It is a very great pleasure to facilitate today's webinar presented by Chantal and Amal, as they are both my dear colleagues here in Montreal at the Hepato-neuro lab. But before presenting them in more detail, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on the Treaty 6 territory, a traditional gathering place for diverse Indigenous people, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your land acknowledgement in the chat box. We would also like to acknowledge Astelas, whose generous support has enabled us to organize this session. Before we dive into the main content, I will pass it to Erika for some general CDTRP update.
Merci, Christelle. Today I have two announcements. Firstly is a reminder that registration is still open for our annual scientific meeting. This year's meeting will occur on December 3rd and 4th in Calgary, Alberta. I'm also pleased to announce that our program is now available on our website, and I encourage everyone interested to go check it out. Second, I'd like to highlight another event happening this year. Dr. Lorraine Hamuka will be hosting a Gairdner Symposium on pediatric transplantation on December 2nd, so the day before our conference. If you plan to travel and attend one of these events, why not extend your stay and attend both? All links will be in the chat momentarily. Thank you.
Thank you, Erika. So before I introduce the speakers, I have a few housekeeping notes. So today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question, comment, you can raise your hand with the raise hand button or type it in the comment section. I am now very pleased to introduce our presenter, Dr. Chantal Bémeur, and her PhD student, Amal Trigui. So Dr. Chantal Bémeur is a nutrition specialist focused on liver disease, particularly hepatic encephalopathy, and she co-directs the Hepato-neuro laboratory at the CHUM Research Center. She has contributed to nutritional guidelines for liver disease patients and developed educational resources for individuals with chronic liver disease and their caregivers. Recognized by the Ordre professionnel des diététistes du Québec, Dr. Bémeur has published extensively and collaborates with the CHUM's Department of Hepatology and Gastroenterology. Our second speaker is Amal Trigui, a doctoral student in nutrition at the Université de Montréal's Faculty of Medicine. With a background in medical biology and health sciences, Amal is conducting her research at the CHUM Research Center. Her work focuses on addressing malnutrition and sarcopenia in liver transplant patients, both pre and post-transplant. So we are very excited to hear your presentation, and I will now hand it over to you.
Thank you, Christelle. We will be sharing our screen in a few seconds. So, hello everyone. It is my great pleasure to talk this afternoon. First, I would like to thank the CDTRP for inviting us to talk about part of our research program. Thank you also, Christelle, for the presentation and for accepting to moderate the session. And finally, thank you to Amal, who accepted to give the talk with me. In fact, she will be giving the majority of the talk today, since it is mostly related to one of her doctoral research projects. So the outline today, we will be talking about chronic liver disease and its complications, including malnutrition, sarcopenia, and frailty. We will also be talking about nutrient intake and diet quality after liver transplantation, and then we will summarize and conclude. So, as you may know, liver disease is a major global public health problem in Canada. According to the Canadian Liver Foundation, 1 in 4 people suffers from a form of liver disease. Also, liver disease is among the 10 main causes of death in Canada. And those numbers are expected to grow in the coming years because of, among other things, of the increased prevalence of obesity, which is often associated with NAFLD or MASLD. On the right side of the screen, you can see that these are data from US from 2015 to 2030, and there is an expected increase in the prevalence and incident cases of NAFLD and NASH cases in the US. So what is the main etiology of chronic liver disease? Well, there are several etiologies of chronic liver disease, as you may know. For example, on the slide here, these are results from a retrospective study that our group performed a couple of years ago at CHUM's liver unit in Montreal. As you can see, NAFLD, which is termed here SHNA, accounts for around 18% of chronic liver disease causes, surpassing alcohol-related liver disease, which is represented by 12%. And MAFLD in the US is the most common cause of liver disease, but importantly, it is expected to become the most common indication for transplantation. So what are the major complications of chronic liver disease? So one of the complications is malnutrition. In fact, it has a prevalence of 65 to 95% in patients living with chronic liver disease. There are several factors that can contribute to the development of malnutrition that are highlighted here on the slide. So there is poor dietary intake, malabsorption, disturbance of substrate utilization, as well as hypermetabolism. So what is malnutrition? How is malnutrition defined? So it is defined as a nutritional status in which there is a combination of different degrees of undernutrition, but also, which is very important, it can also be overnutrition. And there is the presence of inflammation, which is resulting from reduced food intake or nutrient absorption or over food intake also. And this will induce a change in body composition and also a decrease in physical and mental functions. So here you have a pie chart on the right side of the screen that illustrates the results of an ongoing study at the CHUM here in Montreal. This shows that a vast majority of patients living with cirrhosis, in fact, 84% of these patients of different etiologies are at risk of malnutrition. So the risk of malnutrition was assessed in this ongoing study by the liver disease undernutrition screening tool, which assesses nutrient intake, weight loss, loss of fat and muscle mass, as well as fluid accumulation and decline in functional status. So one of the many consequences of malnutrition is sarcopenia. So what is sarcopenia? It is defined as severe muscle mass loss, and it is also based on 3 criteria, which are low muscle strength, low muscle quality and quantity, as well as low physical performance. There are many contributing factors to sarcopenia. So you can see here on the slide, we have aging, disease, including obviously chronic liver disease, inactivity, but also, as I was mentioning earlier, there is also malnutrition. So undernutrition, malabsorption, or overnutrition, obesity that can contribute to the development eventually of malnutrition. Now, what are the consequences of sarcopenia in the context of chronic liver disease? So there are many consequences, but one of them, which is very important, is survival. So studies from colleagues in Edmonton nicely show that survival is significantly decreased over 2 and 3 years in patients living with cirrhosis and who suffer also from sarcopenia, as you can see with the dotted line, which represent patients with sarcopenia compared to the full line, which is patients living with cirrhosis but with no sarcopenia. Another complication which is greatly associated with sarcopenia in the context of chronic liver disease is hepatic encephalopathy, which we are extensively studying in our team. Hepatic encephalopathy has a prevalence of 30 to 80% in a patient with liver disease. It is a serious and debilitating neuropsychiatric syndrome. It is characterized by cognitive, motor, and psychiatric alterations, and importantly, and obviously, it will impact negatively quality of life. One of the pathophysiological factor of hepatic encephalopathy is ammonia. And why are we interested in studying ammonia, hyperammonemia? It's because the muscle plays an important compensatory role in ammonia detoxification during chronic liver disease, as it contains an enzyme that is called glutamine synthetase that will transform glutamate with ammonia into glutamine. And it has been shown that sarcopenia and myosteatosis, which is fat infiltration into the muscle, are associated with hepatic encephalopathy. Here you can see that there are several studies that looked at the association between sarcopenia and HE. And we did write an editorial a couple of years ago on identifying the muscle as a target, an interesting and relevant target for the treatment and prevention of hepatic encephalopathy. Another interesting result related to sarcopenia in the context of chronic liver disease is displayed here on the slide. These are results from a retrospective study, including 79 patients living with cirrhosis who underwent liver transplantation at our center in Montreal at the CHUM. We assess skeletal muscle mass using the gold standard skeletal muscle index with the CT scan at the level of the third lumbar vertebrae. What is interesting here is that in patients with chronic liver disease before liver transplantation, there were 46% who were sarcopenic, and a significant proportion were still sarcopenic after liver transplantation. But what is even more concerning is that among the patients that display no sarcopenia before transplantation, there were patients that, in fact, 42% of them develop sarcopenia after liver transplantation. So it's quite concerning, and we need to address these concerns also. And you can see here on the right part of the slide that skeletal muscle mass index is negatively and significantly correlated with the length of hospitalization after liver transplantation, the episode of infection, as well as the number of complications. Finally, before giving the floor to Amal, I would like to introduce another concept that is related to muscle. It's frailty. So frailty refers to physical frailty as a phenotypic manifestation of loss of muscle function. It is strongly linked to mortality, risk of falls, depression, and decreased quality of life. And its prevalence is ranging from 17 to 42%. It is also present in 59, 41, and 32% of patients at 3, 6, and 12 months after liver transplantation. And it has also been reported that only 20% of patients will achieve functional robustness 1 year after liver transplantation. So now I will give the floor to Amal, who will talk to you a little bit more about the results. Thank you.
Thank you, Chantal. So Chantal has previously shown you the risk factor of sarcopenia in general, but here I'm going to focus more specifically on the risk factor of sarcopenia in liver transplantation context. When we see the liver transplantation context, we have the 3 phases: the pre-liver transplantation, the phase before the transplantation, the perioperative phase, and the post-liver transplantation phase. For the pre-liver transplantation phase, risk factor could be more concentrated on the complication of liver disease itself, for example, the increased ammonia, the systemic inflammation. However, we see other risk factors such as reduced physical activity and nutrient intake. In the perioperative phase, the risk factors are more associated to the surgery itself, as it induced hypercatabolic state and increased stress response. And after the surgery, one of the major risk factors of sarcopenia is immunosuppressive medication that has been proven to affect negatively the muscle. But we can see also other risk factors, for example, physical activity also and nutrient intake. So here, as you can see, the reduced nutrient intake is a common risk factor in the pre- and post-liver transplant phases. For that, we asked the question, and we were curious to know if there is any nutritional intervention that have been proven effective for improving muscle mass or function after liver transplantation. And to answer this question, we did a review which has published in 2023 in the Journal of Nutrients. And following an extensive search, we identified 25 articles of nutritional intervention post-liver transplantation that we could categorize them in 6 different groups. First, we have the BCAA, the branched chain amino acid, then the HMB, which is called also beta-hydroxy beta-methylbutyrate, which is a metabolite of leucine. We have the immunomodulatory diet, the internal nutrition, pre- and probiotics, and finally vitamin D. Among these 6 different types of intervention, those that showed a beneficial effect on parameters related to muscle health were BCAA and HMB only. The others show beneficial effects on other parameters, for example, the reduction of infection, the reduction of acute cellular rejection. Another interesting finding from this review that we see in this figure, the 25 articles identified, most of them were in the early phase after liver transplantation, specifically in the first 13 days after the surgery. And there is a lack of long-term nutritional intervention studies in this population. In addition, you should know that there is no long-term nutritional recommendation for liver transplant recipient. So based on that, we decided to explore the nutritional characteristics in the long term of liver transplant recipient to identify maybe a potential gaps in their dietary management. So we did a cross-sectional exploratory study with adult patients with cirrhosis who underwent liver transplantation at CHUM between January 2019 and December 2021. Out of the 181 patients transplanted in this period, and after excluding non-eligible patients, we were able to include 66 patients that we divided in 3 cohorts. We have the cohort A patient transplanted 1 year ago, the cohort B patient transplanted 2 years ago, and the cohort C patient transplanted 3 years ago. And from the cohort A and B and C, we excluded 2 patients in each of them because they weren't able to complete the 24-hour dietary recall that we're gonna use it for the data after that. So to finish, we have 62 patients included in this project. So here I'm gonna show you the characteristics of the patient included. Here we have the total, then the 3 cohorts identified with the p-value to represent if there is any difference between the 3 cohorts. So to start, the mean age of the patient at the moment of data collection was 63 years. There is twice as many men as female in the group. And the most frequent etiology of liver disease was non-alcoholic steatohepatitis, or NASH, followed by alcoholic cirrhosis. And this data represent accurately the data that Chantal presented previously of the CHUM patient and with the most common etiology. After that, the most common comorbidity in this patient was hypertension, which is present in 47% of the patient included. But we see a high percentage of other risk factors of cardiovascular diseases here, for example, diabetes, obesity, dyslipidemia, and this confirmed that these patients are at high risk of cardiovascular diseases. And to finish, there is non-difference in all the characteristics I presented between the 3 cohorts. This indicates that our groups are comparable. After that, so here we did the macronutrient assessment, meaning the carbohydrate, protein, lipids, and we found that there is also no difference between the three cohorts. This indicates that macronutrient intake remain maybe the same almost over the 3 years post-liver transplantation. And when we compare our data with what reported in literature, we can see some variation in the caloric intake expressed in kilocalorie. This variation could be explained by the variation in participant characteristics. For example, some group may have more female compared to male, which we know that gonna modify the caloric intake in kilocalorie. There is also a difference in time post-liver transplantation, comparing patients included after 1 month after liver transplantation to 7 years. We expect to find some differentiation in caloric intake. Also, a difference in countries, since we know that dietary habits could change from a country to another, from diet to another, and dietary intake assessment method. After that, we compared the percentage of energy from carbohydrate, protein, and lipid with the acceptable macronutrients distribution ranges. And we found that the percentage of energy from carbohydrate and protein was within the recommended range. And for total lipids, it is in the higher limits of the recommended range, which is 35.3 out of 35. So here it is an interesting data because we know that these patients are at risk of gaining weight and obesity in the long term after liver transplantation. So this should be considered in the development of recommendation for these patients. And then we also were interested to compare our data with the ESPN recommendation, the European Society for Parenteral and Enteral Nutrition, which recommend the early initiation of oral food intake and internal nutrition post-liver transplantation with an energy intake of 35 to 40 kilocalories per kilogram per day, and the protein intake aiming 1.2 to 1.5 gram per kilogram per day. So if we compare what we found with these recommendations, we see clearly that up to 3 years post-liver transplantation, energy and protein intake did not meet the ESPN recommendation. We know that these recommendations were developed for the early phase after liver transplantation, but it is unclear for how long these recommendations should be considered after the surgery, and we want to explore more to be able to answer this question. So for that, we did a screening for sarcopenia and physical frailty using questionnaire for this population. And here in the figure in blue, the cohort of 1 year post-liver transplantation, in gray, the cohort of 2 year post-liver transplantation, and in green, the cohort of 3 year post-liver transplantation. First, we have the screening for sarcopenia. After that, for physical frailty, and then the patient who identified pre-frail. So if we see this data, if we compare cohort 1 year to 3 year, we see that the percentage of patients at risk of sarcopenia, it's almost the same for also frailty and pre-frail. So the risk of sarcopenia and frailty do not decrease with years. However, we see some variation in cohort 2 years. This variation could be explained by the smaller sample size in this cohort compared to the others. And also, I want to mention that this cohort is the cohort of the famous year 2020. So COVID could also have an impact on the prevalence that we see here with the lockdown and the decreased physical activity that could affect these numbers. So from this, we can conclude that some patients may need higher protein intake for a longer duration after liver transplantation to avoid the risk of developing sarcopenia or physical frailty. And as Chantal previously showed, there is 42% of patients developed sarcopenia de novo after liver transplantation. So they are at risk of these complications, and these complications are correlated with increased risk of mortality and other complications. So maybe having an early protein intake only in the early phase, it's not sufficient for these patients. After that, we assessed for micronutrients. Here, I'm showing you the vitamins and minerals in the table. The only vitamins that were different between the three cohorts was vitamin K, which reduced significantly with years. Then from the vitamin A, D, E, and K, which is the four fat-soluble vitamin, we noticed that the average level of these four vitamins were below the Canadian reference values. And lastly, we found that sodium intake exceeds the recommended level for the Canadian population. This is just conclusion from what I said earlier. And why these four vitamins are below the recommended level? This could be explained by low consumption of fruit and vegetables. Because patients after liver transplantation, they are immunosuppressed patients, and they may have received some recommendation to avoid consuming raw vegetables after surgery to avoid the risk of contamination. But it's important to note that these vitamins play an important role after surgery. For example, vitamin A, it helps to regulate the immune system. Vitamin D, K, and E, three of them are associated with muscle mass and function. So supplementation of these four vitamins after surgery should be considered. After that, beyond the diet intake and the consumption of macro and micronutrients, assessing diet quality is interesting. So for that, we assessed the adherence to Mediterranean diet using the Mediterranean score to see if the dietary habits of our patient correlate or no with this diet. And as you may know, the Mediterranean diet is a diet that promotes plant-based food, a healthy fat, olive oil, nuts, to limit red and processed meat and dietary product, and consuming fish regularly. In our study, so used this score to assess adherence, and we found a total score of 18 out of 44. This score indicates a low adherence to Mediterranean diet. And as you may know, Mediterranean diet is associated with a reduced risk of cardiovascular diseases. So considering administering this diet in this population could be interesting since these patients are at high risk of cardiovascular diseases post-surgery. After that, we assessed also adherence to the recommendation in the Canada's Food Guide of 2019, which is the recent Canadian Food Guide. And as you may know also, unlike other previous guides that was published previously, this guide emphasizes whole food and plant-based options while moving away from specific portions to specific ages and sex as the guide of 2007. So there is 4 portions recommended. So half of the plate they recommend to have half of it with the vegetables and fruit, 1/4 with whole grain, and one quarter of protein food. So based from this guide, the expert developed an index, and they called it the Healthy Eating Food Index 2019, which assessed the adherence for this guide. And they developed 10 components and with a total score. The total score of this population was 39 out of 80. And this indicates also low adherence to the Canada's Food Guide of 2019. If we compare our data with what published in articles, there is the study of Prasad and all that reported an average score of 43.1 out of 18 in Canadian participant. And here I'm not talking about liver transplant recipient in general. So this could be coherent with what we reported in Canadian participant also. So if I want to summarize the data I represented, up to 3 years post-liver transplantation, patients are at risk, still at risk of sarcopenia and physical frailty. Energy and protein intake do not meet the ESPN recommendation, and lipid intake is in the higher limit of the acceptable macronutrients distribution ranges. For vitamins, fat-soluble vitamins A, D, E, and K, they are below the recommended level for a healthy Canadian population, and sodium exceeds the recommended level. Finally, participants show a low adherence to the Mediterranean diet and the 2019 Canada's food guide. From this, we can conclude that after the acute phase post-liver transplantation, there is a need to develop an evidence-based dietary guideline that are tailored for liver transplant recipients, with recommendation to treat malnutrition, sarcopenia, and promote long-term health. And this, it may include weight management and cardiovascular risk reduction. Before finishing, I want just to mention that we are also working right now on a nutritional intervention study post-liver transplantation. This project, we are randomizing patients after liver transplantation in two groups. We have the control group that receives standard care and routine nutritional advice after surgery, and the intervention group that receive, in addition of the standard care, nutritional supplement rich in protein, energy, and HMB. Before liver transplantation, we are following these patients every 3 months till the transplantation to screen for malnutrition, to assess their muscle function, and to evaluate their quality of life. When patient is in the hospital for liver transplantation, we do a CT scan to assess his muscle mass and finish the definition of sarcopenia. And after the surgery, there is 2 other assessments at hospital discharge and after 12 weeks of intervention to assess all the parameters I mentioned before. In this project, we control for the adherence to supplement with urine collection and a diary of supplementation. We also control for physical activity and protein intake with appropriate questionnaire. And this project, the data collection of this project will end in December 2024. And I will be happy to present the data in another opportunity with you. I should mention in this project, we encountered different maybe logistical and recruitment challenges, but I really learned a lot working with this fascinating population. So I finished my part. So I hand it back to Chantal to conclude the presentation for today.
So thank you very much, Amal, for your presentation. So I would just like to finish with a big thank you first to our patients and their caregivers, and also to Christopher Rose, Mélanie Tremblay, Christelle Hogg, and also all the members of our fantastic Hepato-neuro lab we are very happy to be able to work with such a fantastic team. We also like to thank all our collaborators at the CHUM, and also all the funding agency, and obviously the CDTRP for their continuous support. So thank you, everyone, and we are now ready for questions.
Thank you for that excellent presentation. It was very, very interesting. So now I will open the floor to any questions. Don't hesitate to ask question or write it in the chat box.
I can start off with a question.
Yeah.
You mentioned in your presentation that it's not advised for patients who go through a liver transplant to have vitamin A, K, E, and F. I might have said those wrong. Can you explain why?
Here we are talking about the post-liver transplantation, right?
Yeah.
So why we should consider this supplementation, or why they have deficiency in these vitamins?
You mentioned, I think it was on slide 30, that it's advised for patients not to have these due to contamination. What contaminations would they get through eating raw fruits and veggies?
Yeah, I justified why they have deficiency in these 4 fat-soluble vitamins. I said because they may consume less vegetables and fruit, and they are advised to not consume these raw vegetables because of the risk of contamination. So they need to, these patients are immunosuppressed patients. They could have, they are more vulnerable for infections. So maybe there's specific protocols to clean the vegetables and fruits and to avoid some specific foods to avoid the foodborne contamination. That's why.
Merci.
Thank you.
I think Sandra, you have a question?
Yeah, great presentation. I look forward to getting the package to read some of the details on the data that you found. But I found that, like for my transplant, or you looked at the ones with PSC and PBC. I think it was number 3 there. Many patients who have those diseases, well, definitely the PSC, also get IBD, inflammatory bowel disease, which could be Crohn's or colitis. So our diet is really affected. So like when I had that, I couldn't eat vegetables or fruit because they were very hard to digest, and it would add to the symptoms I had with my Crohn's disease. So then you get used to a carbohydrate diet and stuff like that. But I found, like, even when my transplant's a long time ago, but I've looked at nutrition many times. And, you know, today you showed the Mediterranean and you showed the Canada Food Guide. But I like, and then you go home and then, you know, you follow it. But at different stages of the transplant, like, for example, if when I was chronic kidney disease, there are certain things I had to avoid that are on that list. And now that I'm on dialysis, even more so. But, you know, on dialysis, you're not supposed to have as much protein, I believe. But it's preferred if someone has fibrosis of the liver to get more protein. So I've always found, and, you know, I'm more of a complicated case between, you know, the Crohn's, the liver, and the kidney, what to eat. So I really like to see AI in the future, which is something I'm doing with Dr. Bat. Look at more precision medication, because like the vitamins that you say that we're short of, unless I ask for it, like to be on my blood work, it's not there. I had to push for getting my vitamin D, my vitamin B12. So then we have to start looking in clinic and say, well, if we want patients to have a certain balance on these medications, then we should be measuring them and we should be showing the importance of it. You know, and, you know, this is 27 years in the go, like we know this information itself, but I think that if we look at, you know, nutrition around liver disease, pre, post, and after, and doing things more from a precision base and an individual base, I know it's going to be harder, but, you know, our bodies are all different. We're all at different stages and things like that. And, you know, sarcopenia and muscle weakness and all that. I have that, but I also had 16 years of being on prednisone for Crohn's disease. But then you see other liver transplant recipients out there that are, you know, doing really, really well as athletes. And then you're wondering, well, why they're not suffering from the same thing. And I guess it all comes back to the diet and exercise as well. So thank you.
Thank you, Sandra, for this very interesting comment. I think nutritional intervention should be also personalized based on each profile of each patient. They could have a general recommendation, but after that, each case is different, and you are really right. Maybe it should be personalized for each specific patient. Thank you so much for your comment.
Thank you.
Maybe I can ask a question, more a specific question about how the score for the Canadian Food Guide adherence was calculated, because you show the result for the adherence score for nutrient intake, like proteins and vegetables and stuff. But in the new guide, there's a big part also about the behavioral recommendation, like to cook more often, to eat with family and friends and all that. So I was wondering if the score consider this behavioral recommendation in the score.
No, the score does not take into consideration this behavioral recommendation, because in the guide, as you well explained, there is the part of the plate with the half of the vegetables, fruit, 1 quart of grain, whole grain, and 1 quart of protein. But there's also another part of the guide that recommend dietary habits, for example, eating with good company, cook well, cook more often at home. But this score was developed to assess only the first part of the guide. And they developed the score with expert, after expert, how can I say it, avis. So they are working, the same group, they are working right now to develop another tools to assess the behavioral changes of the second part of the guide, but it's not yet developed. So
Okay.
answer your question, the index only assess the first part of the guide.
Thank you. Any other question from the audience? Oh, Sandra, yes, you can feel free to ask your question.
Just reading what Donna wrote. Yeah, so we have a bigger world problem with this nutrition, okay? So for example, you look at the number of people that have NASH, and I know it's the non-alcohol, but then there's the other one that used to be like fatty, but it's got to change. Chantal, you know what the new name is. But you look at the cost of our foods and the cost of eating good, and it's very expensive. And you look at like, you know, with our environment, what's happening with our farming and things like that. So we have to, and not CDTRP, but some of us have to like start advocating for our foods, because we're going to have more episodes of diabetes, heart disease, and obesity, because everything that we go out, like I become so cautious about everything that I'm eating, because I have to watch my potassium, my phosphorus, my sodium, and obviously sugar. And there's everything that we have has all those things in there, right? So you have to look at it unless you get educated. And I'll tell you one thing, I've been looking at my weight since I was 12 years old with the diet, the banana diet with my girlfriends, right? And it's just, I got so much information, I almost could have been a nutritionist, but it's just so overwhelming for people. And then especially when they go to the food and they look at like I haven't been shopping since before COVID. My husband does it, but I've been out a few times with him lately. And I'm just overwhelmed how much things cost. And, you know, when you go to look at like, okay, we'll buy a salad or buy something healthy. And these, you know, we still do, but it's like, you know, other people probably can't afford it too as well. You know, and we have to really seriously look at like, you know, if there's other places we can get it, like at farmers markets and things like that. So I'm not going to solve that today, but I think it's very important that it's something that we look at. Why, you know, you're seeing more people that are obese and getting fatty liver disease.
Thank you, Sandra, for your comment. And it's very interesting. And I should say that it's a concern also that we have, but obviously the cost of food is rising since a couple of months and years also. And one of our, another student in our lab is working on education strategies for patients living with cirrhosis. And we are also addressing this, we are trying to address, because it's very complicated, you know, as you know, and we discussed it quite some time ago, but I think that it's very important point that today we discussed about the intakes, you know, the guide, the Mediterranean diet. We know that it is maybe not suitable for everyone, and that we need to look at case by case, and that there are a lot of things to consider. So, but I think that with these kind of conversations, we can hope to maybe achieve something and to get there. But it's very important to take into account and to consider. Thank you for your comment.
We have a question in the chat by Donna. Do you have any recommendations for a Mediterranean diet cookbook?
Sorry, but I don't have a recommendation for a book. We know for the pyramid I presented previously the composite of Mediterranean diet, but for my part, I don't know a cookbook. And maybe something should be considered in the future recommendation for a patient after liver transplantation, to have specific recommendation, not only a general one, with to address the specific component of the pyramid of Mediterranean diet in this population. But me, I came from a Mediterranean country, so I know the diet very well.
Yeah, that's a good question for the cookbook. Yeah, it's it does not come in my head for the moment, but I know that we have maybe you know the Nutrition in Cirrhosis Guide. That is, it's one of the tool that is used. It was developed by Punita Tendon in Alberta, and it includes like recommendations related to the med diet. But I think that could be a great addition to have a cookbook, especially or exclusively on the med diet.
Thank you, Chantal. I think Sandra, you were wondering what are your thoughts on the intermittent fasting diet? Is it healthy for people with liver disease? What are your thoughts about it?
So yes, it's a good question, and we do hear a lot about intermittent fasting and also as the keto diet. For the moment, we do not have any strong recommendation, especially over the long term in human. We do have some results in animal models that show, I would say, variable benefits. So until we have more solid data, I would not recommend that for people with liver disease. So that's, I think, the safest answer that I can give today. But yeah, we need to look into that because a lot of research is going on related to intermittent fasting and also keto diet.
If I can add, another thing also, this is for the cirrhotic patient before liver transplantation, but after liver transplantation, patients are avoided to stay longer period without eating. This is after the surgery. And also the ESPN recommend to take a late snack before sleeping to avoid having a long period without any food. With the hypercatabolic state after surgery, with all what happened after surgery, it is really not recommended to stay long period without any food. Especially for protein, I would say, because it's recommended to have a snack with a high protein.
Thank you, Amal. Erika, you want to ask another question?
Yes. You did a macronutrient assessment throughout your project, and then you reported the macros through all your patients. What program did you use to track the macros, or is this self-reported?
So thanks for your question. It is by the 24-hour dietary recall. It is web version. Patient, we invite them to complete 2 dietary recall. They report themselves what they eat during the 24-hour in 2 different days during the week. So themselves, they introduce what they eat in the breakfast, in dinner, after, even if ils ont pris des collations, they put everything there. And then the platform generates itself the median for, the mean for every 2 days for each patient. And
is it fairly accurate, or what would be the estimate of how off it is?
It is the most recommended tools to assess the nutritional intake. So it is one of the most recommended one, and based on that tools, the Healthy Eating Food Index also was developed, and this tools was able to generate these scores. So it is very used, and I think it's one of the most recommended tools to assess nutritional intake.
Thank you.
And if I may add to Amal's answer was perfect. It is there is no ideal tool to to capture nutritional intake. So it's very difficult, but the one that Amal used is a validated one. It was developed and validated by a team in Quebec, and it has been they validated and demonstrated that if we take like 2 days, like she mentioned, one on the weekdays and one on the weekend day, that it's especially for the macronutrient, it is relatively precise according to the intake of the patients. For the micronutrient is like it's a little bit more I would say difficult because it can vary a lot more than the macronutrient, but it gives us an idea at least of the intake of the participants.
Thank you, Chantal and Amal. Maybe we have time for one more question if someone still have a question. Yes, Chris?
Hello. Great talk. I have a question. We've probably discussed this amongst ourselves before, but sometimes I do forget. Where does exercise stand as far as post-liver transplantation, rehabilitation, and so forth? I mean, we talk a lot about nutrition, but is there any exercise that's recommended?
For exercise, physical activity, I would say there is no solid recommendation in the early phase after liver transplantation. I know that in the first phase after surgery, patients should not, for example, take a very lourd object, very heavy objects. They do have some limitation in doing some kind of physical activity. But I know there is a lot of study working to test different physical program if they're efficient after liver transplantation. In the long term, I would say I don't remember seeing also recommendation for physical activity, specific recommendation, but it's recommended to do physical activity, and since it could help for cardiovascular risk reduction and yeah, complication after surgery. But I do remember having slides showing this kind of recommendation after transplantation. I can't show it after that. If I can able to share again my screen. I want to add something.
Yeah, I just wanted to say, Chris, the CDTRP under this theme that Chantal and I lead has a whole exercise, and it's got two names, doesn't it, Derica? Is it exercise and therapy? Exercise hub. Anyway, it's led by Dimitri Rosenberg. I think his webinar is coming up next, right? But there's been so many studies done on exercise, and but again, it's different. He's focused more on lung, but we are starting to look more at other organs.
Yes, many studies are performed, and we are also doing a scoping review right now on exercise and nutrition. But I think that even if there are many studies, like Amal said, there are no recommendations for the moment. A lot of studies are also are being performed with prehabilitation, so before the surgery, so to to improve the condition of the patient, and this is also an interesting avenue. But I think we need to look into that also.
Thank you so much. So I see the time. I want to thank you for everyone for questions and comments throughout today's presentation. Dr. Chantal Bémeur and Amal Trigui, on the behalf of CDTRP, thank you again for presenting. If anyone has additional comments, questions, or suggested topics and speakers, please contact Erika Croft at ekcroft@cdtrp.ca. So with that, I will thank you everyone for your presence today, and I enjoy the rest of your day. Thank you.